Good morning, depending on where you are in the country. My name is Garrett Schmidt, and I'm the CEO and managing editor of VBC Exhibit Hall. And I'd like to welcome you all to today's live panel discussion called The Most Creative Ways to Close Gaps in Care, meeting patients where they are. And we've got several exciting guests that I will introduce here momentarily, but a few items of note of housekeeping before we get started. Everyone has joined today in listen-only mode, so this is a kind of a traditional webinar format, so we can't see you or hear you, but we are going to have a time for some audience questions, hopefully towards the end. So if you have a question for our panelists that you would like to address, go ahead and at any point during the presentation, you can use your control module. There's a space for questions. Go ahead and drop your question in there. If we don't get to yours, for some reason, if we run out of time or whatever, we got a lot of material to cover. But if we run out of time, don't worry, someone will reach out to you via email to make sure that your question gets answered. And then finally, the session today is being recorded. So when we conclude, maybe about an hour or so afterwards, you will receive an email. And that email will have a link to today's recording. And that way you can review it at your leisure and or share it with your colleagues and friends. And we hope that you do so. So without further ado, today's session is a little bit different in terms of format. This is going to be a little bit more of a conversational format with our speakers exploring a series of pre-selected questions related to the topic. And I will be moderating the discussion today. So without further ado, let's jump into some introductions here, and I will let them do the introductions themselves because they have a much further background on their own expertise. And so starting with you, Nikki, I was wondering if you could give us maybe 30 seconds on your background. Welcome, Nikki.
Sure. My name is Nikki Hoshmand. I currently serve as a director of growth at Firsthand. A little bit about my background is it spans across strategy and ops roles. Across the healthcare ecosystem, I spent the entirety of my career within healthcare, from early stage startups to large enterprises. Across the board, I spent most of my time helping mission-driven healthcare orgs scale sustainable models of care. At Firsthand specifically, I lead our go-to-market and business development initiatives, all centered on expanding access to care for the SMI population, which is highly underserved, unengaged, and highly distrustful of healthcare.
Wonderful. Eric?
Yeah, hi everyone. My name is Eric Alvarez. I am the proud CEO and founder of Grapefruit Health. We are headquartered out of Chicago. My background is over 15 years now in healthcare, starting off with leading some large service lines, over 150 FTEs for Northwestern Medicine, University of Chicago Medicine. Got into healthcare innovation 10 years ago now, joined a startup as their first employee and chief operating officer in referral management SaaS. Went on to get acquired by Cerner, and now leading the helm here at Grapefruit Health for the last 3.5 years plus.
Wonderful. And Peter Johnway.
Hey everyone, I'm excited to be here. I'm the proud CEO and founder of Oben Health. My background is in computer science, worked at different tech companies. Oben Health is based in San Francisco. And so having worked at different tech companies, I wanted to use the knowledge I've acquired to build something in healthcare that meets people where they are. I started Oben as a result of a personal loss. I lost a family member due to undetected hypertension. And that became the genesis for starting the company of how we could build a solution to meet people where they are in communities that are severely underserved. So excited to be on this panel and excited to talk more about how we can close those care gaps.
Wonderful. And at this point, let's maybe circle back around, and I'd like to get maybe just about a minute or two overview of your organization. And Nikki, maybe back to you. Can you tell us a little bit about Firsthand?
Yeah, absolutely. So Firsthand is a value-based care provider focused specifically on individuals living with serious mental illness, a population very often left behind in traditional healthcare systems. We serve Medicaid, Medicare Advantage, and dual eligible members across 5 markets today: Washington, Ohio, Michigan, Virginia, and Florida, with plans to expand to new markets in the near future. Within each market, we have interdisciplinary care teams that began with our Firsthand guides. The guides are peers from local communities who have shared lived experience with our individuals who've dealt with the same challenges in the same places and came out stronger on the other side. Our peers leverage this shared experience to build trust with members and are also licensed as community health workers who are trained to support these individuals in their care journey after building that trust. Our peers are the ones who go out within the communities and find, engage, and rebuild with these individuals who otherwise remain largely disengaged with their own healthcare due to systemic distrust, which leads to, on the other end, high frequency of ER visits, high inpatient utilization, preventable poor outcomes, and ongoing disengagement, which just continues to fuel the cycle. After our peers engage these individuals, they then work alongside clinicians who are RNs that are dual certified in both primary care and psychiatry, who then work to close care gaps and work alongside social workers who connect these individuals to community resources and address any social determinants of health. Overall, this peer-led, clinically integrated model is meant to really improve access to care through trust, addressing social needs, staying connected, and then getting to those care gaps by meeting people where they are, in most cases, people who don't often have a stable place to call home.
Wonderful. Thank you, Nikki. Eric, can you tell us a little bit about Grapefruit Health?
Yeah, I'd love to. We are closing gaps in care in a pretty creative way. Today, we employ about 300 clinical students, and that's anybody on a clinical educational path, mostly nursing, but also social work, pharmacy, pre-med, dietitian students. Believe it or not, there's over 1 million of these students in the country at any given time. We have another 30,000 or so in our network. And what those students do is that around their schedule, the students work directly for Grapefruit Health. So we are technology-enabled healthcare services. We're not a marketplace or staffing firm. And around the schedule, their own schedules, those students, they log into our platform. They click a button to generate an interaction, and they're matched to patients based off language and culture and proximity to that patient's home address, which really drives trust. The students already understand the SDOH issues that are going on, their accents and dialects, they match that of the patients. And then they go through a very scripted experience. So if we're doing post-discharge follow-up or medication adherence, it's all done within our application, and we close gaps in that format. We also have a very unique pricing model where we charge really on a per effort basis. So we don't do PM or licensing. It's really pay for what you get. So that's our creative approach.
Very good. Thank you, Eric. Peter, could you tell us a little bit about Oben?
Absolutely. Yeah, so at Oben, as I mentioned, we're building the infrastructure to deliver health in non-traditional spaces, starting with barbershops and salons. And so really fundamentally, we've taken a public health model that has been shown to be effective. There's a 2018 LA study that had shown barbershops and salons are really good places to deliver healthcare, and have 60%, the evidence has shown that it's 60% more effective than care delivery that happens in a clinic or at home, just by virtue of trust and people going there often. And for me, as I mentioned a little bit earlier, part of the genesis of starting this company was I lost my brother to uncontrolled hypertension. He was 36, and he went to bed and he didn't wake up. And that was a really important thing for me, where it wasn't just about the science or the medication, which we do have, we know how to do that, but it was about access to care. It was about, if he had known what those blood pressure numbers meant, we'd still be here. And we know how big of a problem that is in the country. And so what we decided to do is facilitate barbershops and salons. And so part one of that infrastructure is we train and certify the barbers to be community health workers. So if a client walks into a barbershop, the barber is able to screen for hypertension. We give them the technology tools where that screening data can be captured. We're able to assist them in walking the client through what that actually means. And we're integrated with all your tools, right? So it's not just a one-time screening, is when the client comes back to the barber, every subsequent visit becomes a community health worker interaction. So they're providing health education and screening. We're also providing all the clinical tools for that client to get care in that space and getting that data back to the plans. And so, yeah, we've been focused on California. We work with a lot of Medicaid plans. We're starting to work with commercial plans, and we're looking to, expand across the country.
Very good. Very good. Well, let's dive into our discussion for today, and thank you all for joining us. And our topic at hand today is meeting patients where they are. And let's start, Nikki, with you. What does meeting people where they are mean in practice at your organization?
That's a great question. I would say for us, it is something that I would take both literally and relationally. Our peers are embedded within the local communities, so they've gone through the same challenges as many of the people that we serve in the same places. They meet members in their homes, they knock on doors, they visit shelters, they go to the same parks, wherever they know they might find a member and wherever they can meet them to make them feel safe and comfortable. On the other hand, our approach also means meeting members emotionally where they are. Recovery is nonlinear. Many of our members have had difficult or even traumatic experiences with the healthcare system. And our peers, because they know what that's like, can connect on a human level first. So in addition to going out within the community with this boots on the ground approach and meeting them physically in the same location, they have a trust that serves as the foundation for everything else, whether it's helping someone see a primary care provider or having conversations with them until they're actually ready to see a primary care provider and trust a clinician. It might be helping them find and stay on the right medication and talking through what that means. Or it could be even before we get there, addressing their housing instability. So I'd say that's probably how we approach meeting people where they are, just to build that trust and engagement.
Great. Thank you. And I'll offer that same question, Eric and Peter, if you would like to speak to that in terms of your organization. What does it mean to meet patients where they are?
Peter, you want to go first?
Sure, I'll jump in. Sorry. I think for us, meeting people where they are is meeting people where they feel safe, where there's trust, where they go often. And that's why we really focused on barbershops and salons. One of the things that that really stood out for us is how often people go back to a barbershop or even a salon, right? So they're there 12 to 24 times a year. And it's not just how regular they go, it's also just a space where they have all sorts of conversations. They've known these barbers for a while. Some of them have 5-10 year relationships. And you also know, like, breaking up with your barber is probably the hardest thing you would ever do. So that's the true definition. I mean, every time I've broken out with a barber, I just never go down the same street. It just doesn't happen. That tells you how hard that is. But I think we've tapped into that, right? Because that is essentially what we've built is you get your haircut, you get care done. You don't have to think about it. You don't have to book an appointment to see a doctor. You don't have to think about the logistics around it. It's really about simplifying access to care and making it really convenient for the patient. And so it's location, it's how we certify and train those people that our patients trust. It's how we collect the data. It's really about being in the space that patients are going often and saying, I want to be there, right? And they feel heard and seen. And that really defines what meeting people where they are for Open.
Yeah, I think the last thing I would add is we're different with both Nikki and Peter being more in-person care. Grapefruit Health, we chose early on the modality to be the telephone call. And, we got our start just while COVID was kind of calming down. And even text messaging, believe it or not, if you have a lot of payer clients or partners, you're not allowed to always text message because they have certain communication rules. And so we really settled on the telephone. It is the most widely used form of, remote communication. And so that's been effective for us. Again, we're doing a really high volume nationally, what we're doing. And so the telephone is how we're meeting patients where we are, or they are.
Yeah, great. And I'm curious, in terms of with that explanation, how does this model or how does your model fit into the greater framework of value-based care? Nikki, you want to start?
Yeah, sure. Value-based care, I think, because of the nature of our work, is just a natural fit. We take full accountability for outcomes because our population has extremely high needs, high costs, and extremely thin margins with government products. So traditional fee-for-service models just don't work for this group. they reward volume and not relationship building. For us, when our members feel seen, connected, and supported, they engage and care differently, and their outcomes improve with time. To us, that's what real value looks like. So in terms of our care journey, what that looks like tactically is each member is paired with the peer, who's their first point of contact. Each service that the peer actually provides is a service that produces value but can't be billed service by service. And then from there, we get to a point where that trust is built. Members receive a comprehensive assessment from a licensed clinician who evaluates the whole person, addressing their mental, physical health needs, guides them on their path to recovery. We address their social determinants. Over time, you start to see your return on investment through durable outcomes. We're confident with our model at this point, and our approach takes accountability and focuses on value to the point that our plan partners really only pay us when we produce that value. And that's just something that we've seen work much more as we start to see that reduction in ER visits, that reduction in inpatient utilization, reduction in MedEx, and that improvement in engagement, and not just initial engagement, but continuous engagement. So that's value that we just hope to sustain over time. And because of that, VBC is just a natural framework for our work.
Yeah, great.
Yeah.
Eric?
I think like conceptually the concept of value-based care, the idea of increasing quality and reducing cost is really perfectly aligned with the mission of Grapefruit Health. And so much of the work we're doing in engaging folks around care gaps over the telephone has been done. Even our clients are typically doing it. Our innovation is really in the cost reduction, right? We just said reduce cost, increase quality. And then because they can afford now to do the volumes they need to, they can increase quality. And so anything, even on the fee for value side or traditional healthcare, when we do a post-discharge follow-up, we see reduction in hospital readmissions by 13%. And then the cost of doing that work is 50%. And that's relevant for almost all healthcare provider organizations across the country. And then on the fee for value side, value-based care side, our partners that are doing, Medicare Advantage and ACOs, they have true quality metrics that impact their reimbursement, how they're paid, how they're incentivized to do work. And so by implementing, Grapefruit Health, we help them achieve the gaps in care they need to close in order to get those quality scores to increase their revenues, and then also reducing costs. So if they're deploying folks to perform this work today, we can come in at half the cost and perform it. So it's worked really well for us. The last little kind of component here too, I think that's impacting value-based care is really around staffing, and people are short-staffed. The U.S. is short by 3.2 million healthcare workers. We've tapped into this net new workforce of clinical students. Again, there's 1 million of them in the country. If we can operationalize even a fraction of them, it can really make an impact and therefore increase quality and reduce costs across the country.
Yeah, wonderful. Peter?
Yeah. Just to add to what Eric just said in terms of staffing, I think that's also been a big part of Oben in creating this new care workforce. Again, not just barbers, we're looking at stylists, nail salons, really places where have the same type of interaction and people go up to them that they trust. And so that's a really big piece of what we've been building. And out for value-based care, in addition to what both Nick and Eric have said, it's really embedded in everything we do. And one of the key things, currently about 60% of the patients we see in the barbershop or salons have not had a blood pressure reading for over 2 years. And they haven't seen a primary care doctor in over 2 years. And what that means is that, and once we see them, again, that same number has high blood pressure, right? And they often don't know that this is a symptom or this is what it's going to cause. It's often called the silent killer. And so we're able to actually meet people, get those numbers before anything happens. And that inherently reduces the chances of them having to go to ER, of them having increased utilization costs, and also closing those care gaps that plans and payers care about. So I think that is just inherently kind of what we've been building. And even our business model is really tied to engagement. Again, not just one-time engagement, but continuous engagement by virtue of the people coming to that space often, and us being able to actually create those care plans, and the barber and the stylist helping them adhere to those plans. So our model is really based on that, and specifically, I think, tapping on what we call the holy grail of preventative care, meeting people before something catastrophic happens.
Great. Moving along, Health equity and access is obviously a very important part of value-based care and something that I know each of you strive in your organizations to do. And I'm wondering if you could talk for a moment about how your organization is advancing health equity and access. Starting with you, Nikki, can you tell us a little bit about that?
Sure. I'm sure Eric and Peter would both echo this, but closing care gaps really begins with health equity. It's at the core of what we do. Specifically for firsthand, that means approaching people who live with serious mental illness. So think patients who experience schizophrenia, bipolar disorder, major depressive disorder, heavy substance use. These people are historically disconnected from care. Because of that, they face poor health outcomes. Most of the time, it's from preventable physical conditions that fall behind because of their unaddressed behavioral health symptoms. So by meeting people in their context and actually designing this care around their lived experiences, we hope to bridge gaps in any type of inequity and actually reach these individuals who just cannot be reached with traditional methods. So I'd say for us, health equity it's not just about providing services, it's about offering dignity, choice, access, connection for people who cannot be approached in the ways that we're used to, and because of that have just been marginalized by the healthcare system.
Eric, curious to hear your thoughts.
Yeah, health equity and access go together. I think typically access or lack of access is classified as an inequity in healthcare. And I think the way that Grapefruit Health is advancing both of those, or addressing health inequities around access, is around the staffing shortage maybe. And so a lot of organizations simply don't have the resources to reach out to every single person. For example, on post-discharge follow-up is I think a good example. A clinical nurse might be performing post-discharge follow-up in addition to a million other tasks. And so the lower acuity maybe, or they're out that day, you're missing a lot of these folks. And what winds up happening is the disease set or their needs after an inpatient or ED discharge are not being met or addressed. And so it's extremely challenging. And so this access component to getting that type of care, at Grapefruit Health, we're able to actually reach out to all of those patients because we can scale up these large workforces again at a fraction of the cost. And so what we find is these people actually need something, like desperately. And they often are the underserved. They're the folks that are dealing with the most health inequities, whether it's transportation, whether it's food or something else. And so when you have a human being powered workforce at our scale, we can really close those gaps around discharge. So a lot of times anyways, if everyone's not familiar, post-discharge follow-up, we're checking on your wounds healing. Do you have transportation to get to your PCP visit? Do you have your PCP visit scheduled? Do you even have a PCP? So do you have nutritional food to eat while you're recovering, and those types of things? And so while we're there, we're able to do all of those. Again, when we go into our partner or client sites, they're trying to do this with their W-2 workforce. They have 50 open positions they can't fill. And so Grapefruit Health kind of is advancing health equity and access by closing those gaps around post-discharge follow-up. Is just one example, but I think you could say that for any of the use cases we do.
Great. Peter, what about Oben? What are you guys doing to advance health equity and access?
And Nick and Eric have touched on a lot of things, which inherently do. And and the only thing I'd add to that, which really what is talked about really touches on health equity and access, is that also when we think about health equity, it's about access to information. Do people actually know that they have certain benefits or certain things they're eligible for? Or do people even know, and I always go back to the fact that people even know that they have hypertension, right? I'll give you a story about someone we started a barber shop. He came in, the barber screened him, his blood pressure was 185 over 120. That is hypertensive. That's borderline. You should be, you need to go see a doctor right away. And when talking to him, and he was just like, yeah, my left leg's kind of numb. I get this headaches. I just think it's work stress. And for us, when you're in the health space, you think this information, you're like, oh no, that's a telltale sign. But for someone else, it's just thinking that's stress. That's just like work stress. I don't want, I got to think about booking time at a doctor. Like, it's gonna be a couple of weeks. I just don't want to deal with that. But we're able to see him, tell him what that meant, got him a primary care physician and say, I need you to go in. And he actually was like, oh, I didn't actually know that this is what this is. And like, these are the symptoms. And I think that's health equity. Not just, not even access, but just information, knowing like this is where you are and this is what this information is, and meeting you where you are in terms of just making it really convenient for you to get the care you need. And so just to add it, I think that's a big part of health equity so that people can actually understand, though, not just what access is, but what the information and what is happening with them so that they're able to do something about it.
Great. Well, let's shift gears here for a minute and actually kind of dive in a little bit to the solutions that you guys do. And Peter, starting with you, since we're already with you, how does your solution really work? If I was to ask you that, and how do you actually engage with these patients?
Yeah, good question. So the first step is, or remember, infrastructure is the training tools. So we train our barbers and stylists to be community health workers. And that's really important for them because, again, once they get certified as community health workers, we can, bill for their services. It's additional income for them. So the incentives are aligned. For a lot of barbers and stylists, this additional income they can make anywhere in addition, just again on hypertension screening, anywhere from $10,000 a month extra. And so that's really meaningful for the barbers, right? And so it starts with that step one. And so then the second step is once they're trained as community health workers, a client that walks into a barber shop. So we pair every barber with what we call a community health worker mobile application that we built to fit directly into the barber and stylist workflows. So that when a client comes in, they would say, for example, Garrett, if you're going for a haircut, hey, when's the last time you had your blood pressure taken? As I mentioned earlier, over 60% of our clients, it's been 2+ years, so they haven't gotten blood pressure taken, haven't been to a primary care physician, and that starts the conversation. So the barber is paired with a cuff. They would measure blood pressure or any other, and specifically I start with hypertension, but we do other screenings as well. That data is captured in our community health worker mobile application. It's where then it walks them through kind of next series of questions and triages the patient. So if a patient is borderline hypertensive or elevated blood pressure, we have different routes where the patient can be sent, and we collect that information on the back end, and we follow up with the patient post that visit at the barber. And what that looks like is the barber has collected information like, you have a primary care physician, do you have insurance? We check with the patient. We get them an appointment booked with a pharmacist at your next haircut appointment. And again, everything is really, we try to keep everything contained within that space so that the next time they're back, they see a pharmacist, they see a barber, the care plan that's created by the pharmacist or it could be a physician assistant is shared with the barber. So every subsequent visit, the barber can see, hey, did you actually pick up your medications? Like, how's your blood pressure looking? They're screening and really providing that health education. So it's sort of this longitudinal care that we're able to actually engage patients, again, at least once a month or twice a month sometimes, which is really, we've been really fascinating about our model. So yeah, so that's overall kind of the structure of how Oben works and how we're meeting patients in these barbershops.
Very cool. Nikki, did you want to hop in next on this one?
Yeah, I'm happy to go into more detail on Firsthand's model. I know I've said that we build that trust, we engage, we care for individuals. What that actually looks like in practice is our plan partners will attribute members to us, and then we will take a look at that attribution and risk stratify, figuring out who we should engage at the right time. And then our peers go into the communities and they knock on doors and they visit shelters and they visit parks and they actually try to find these individuals. A lot of the time, that's really more effort than you would think. They'll call pharmacies to find the right address. These individuals really just don't have the same level of data that you'll see in, say, commercial population. And once they do find an individual, it takes, I'd say, maybe 5 to 7 encounters on average to even get to a point where they're willing to actually talk about participating in our program. We don't define engagement until the point that a consent form is signed. So similar to what Eric was describing earlier, we don't charge on a per member per month basis. We charge for per engaged member per month. So also within the value-based care framework, we aren't charging for all that upfront work on outreach. We're only charging for those that say yes to our program. We have a pretty high engagement rate. That being said, is around 45%, which is extremely high for this population. And once we do have an engaged member, then our peers will see how they can actually help out. They're licensed as community health workers in addition to having that shared lived experience. And most often, this individual won't even bring up their serious mental illness. They don't know that the peer even knows that they have a serious mental illness. They will ask for help in getting the right medication, addressing comorbidities, helping with their diabetes or their COPD, helping them find transportation or even get stable housing or get a job. Once they do kind of build more trust, we will get them into our clinician who will provide a whole person assessment. The goal of that is to really get a full picture of both their behavioral health and physical health symptoms and figure out what the right care plan is for them to get them towards stabilization and durable recovery. Throughout that journey, we also have a 24/7 triage line. So these are pretty high ER utilizers. So instead of going to the ER, now we have these individuals actually calling our clinicians. And most of the time, they don't really need an ER visit. 100% of our triage interactions are resolved within 8 hours. Obviously, a small percentage of those do need to go to the ER, but often they just need someone to talk to in a moment where their symptoms are pretty severe, and they just need someone that they can trust who can provide that support. On the social determinant side, we also have community resource specialists. A lot of these individuals are eligible for support, for example, disability, SNAP benefits, but they might not even know it, or they might not even want to try to begin the application process. So we do have folks who actually sit with individuals, get their whole story, and figure out how to get them connected to the right resources. At the end of the day, this full approach is what really leads to value for us. And it does take a full team, but this is really a whole person approach that actually helps these individuals in a lasting way.
Very good. Eric, I had a question that came in from the audience here specifically about what you guys do, and I'll just read this to you here. With the post-discharge calls that Eric's company does, how do these students handle emergent issues, or how do they get them seen by someone sooner if needed?
Yeah, great question. So Grapefruit Health, while we're in our implementation phase with our clients, so the way it typically works is we engage with our value-based care organization, payer, provider, community health, FQHC, whatever it might be. We determine what's the need here. And it could be multi-threaded. It could be several things, but let's just say it is post-discharge follow-up. We work with that partner to finalize scripts, like actual spoken scripts, the data that's to be collected. And then where I'm going with this on the escalation side is workflows. We then recruit, train, onboard, and manage the clinical students from that region. We actually let our partners dictate which schools. Most of our partners want to do a case study or a press release stating that they're engaging local clinical folks to engage patients. It makes for a great story. We have a database I mentioned earlier of about 30,000 applicants. So that process is actually very fast. We just go through our database. And so we're ready to go. So during that workflow process, though, there's always a lot of conversation around escalation. And if you've met one healthcare organization, you've met one healthcare organization. They're all very different. And I was just doing this yesterday afternoon with the third largest health system in the country, actually. And so we are talking about emergent, urgent, and routine escalations, right? An emergent escalation, there's no ifs, ands, or buts. Like, we're going right to 911 with that, suicidal ideation. I don't know where I am. I'm confused. I'm dizzy. Something very alarming. We have a lot of what we call red words, if you will. I'm sure many organizations listening understand that. You then have urgent referrals. It's like something that can't wait a month or a year, but it needs to be like addressed. And so because we are unlicensed, we're not, right? We're pre-licensure. These are clinical students. What we do is a warm transfer, and we can do it to a lot of different locations. It could be back to the primary care's office. So even if it's an ACO we're working with, we do a warm transfer to the attributed ACO. If nobody picks up, we can, again, this is all dictated in the workflow. It could be a detailed voicemail we leave with the patient there. We follow up with the patient with text messages too, to give them their PCP's information. maybe the escalation is, I haven't eaten and we've determined we're going to use find help for that, or I haven't eaten, so we'll do a warm transfer to a food bank that is on those services. We can also go back to like, if the organization's a larger health system, we can do a warm transfer to their central scheduling or centralized process, stuff like that. And then there's like routine, very light stuff that we're going to document. It'll be like we're talking to them about post-discharge follow-up, and they had a shoulder surgery 3 years ago and their shoulder's starting to hurt. We'll still document that and make sure we close the loop on that escalation, which is really like a referral. And so we document that back to the care teams as well. Again, it's all unique to the organization.
It's awesome. Wonderful. Well, let's shift gears here to the next question. And actually, Eric, let's stay with you on this one. How are you leveraging AI today, if at all? And do you have plans to start using it? If so, how?
Oh gosh, yeah. AI is like the topic of the year. Certainly getting heavier and heavier for anybody that was at some of the big conferences this year. So there's a few different ways we're doing it. Internally, of course, we're using it as a business, anything from like accounting and general marketing, or helping us write job descriptions, things like that. And then one step further, Google recently invested some developer dollars, quite a few actually. We're developing artificial intelligent patients, and this is going to allow us to automate some of the training of our students. They'll still have to go through our final training and testing and quality assurance stuff, but this is going to make, we think, much stronger training, much more scalable training. We'll also offer that training as a certificate program for folks that we don't hire. So for that network of 1 million clinical students out there, we'll offer it. We have not pursued patient-facing AI for a few reasons. One, there's a lot of state regs coming out every day for those that are watching, and we just don't feel like we're in a position to stay in front of those, to pivot as they come up, creating headwinds. We're also noticing at our clients and partners, their procurement teams aren't all, and I'm not saying, if you look at a technology adoption bell curve, there's certainly people on the front end that are doing this. But I would say the majority, their procurement teams are not yet established enough to determine governance and how to actually evaluate a pure AI solution. And so they're doing pilots and they're trying to figure this out. At some point, we will have to pursue conversational and patient-facing AI. We're just strategically not doing it yet.
Very cool. Nikki, Peter, curious whether either of you are doing anything with AI or have plans for that. Nikki?
Yeah, I will first say that I hear you, Eric, on AI being the topic of the year. I get asked this question very often. And I'll also say it's great to hear how we're all taking creative and different approaches to the same problem here. For firsthand, I know I keep saying this, but our model is really rooted in the boots on the ground approach. So we're also not working with patient-facing AI. That said, we do leverage AI on the back end, and that's really to make sure that our outreach and engagement efforts are as data-driven as possible. So to give you an example in practice, that could look like employing an algorithm that looks through claims data to stratify members based on what their level of risk is, so that if someone really needs an intervention, we will prioritize those individuals, where if there's a right time for another individual, then we'll make sure that we are matching their needs. So that's really where we would use more of that data analytics and AI capabilities for that risk stratification and just any type of data-driven intervention that we can pursue.
Peter?
Yeah, I'll second that. We're not, again, I know AI is the topic of the day, and everyone's asking how are we utilizing AI, and we've really focused on using AI on the back end infrastructure piece as opposed to more patient focused. And what that means is, so really how we identify the barbershops is when we work with our plans, they give us zip codes that they want to target. And we use the barbershops, we find barbershops in the zip codes and use them as ways to get patients in the door. And so a lot of what we do, so really AI plays a role in terms of building out some of the training modules, like being able to get, helping the barbers train with patient data. And then secondly, as well, it also helps with anything from claim submission. So we really spent a lot of time to make sure barbers are not documenting. When you're licensed as a community health worker, you've got to have documentation, which is what we use to build a plan or submit a claim. So we've really simplified a lot of that, and using AI to, again, making sure that when they submit what services they've done, they're not spending a whole lot of time writing down or documenting pieces. So that's where AI plays a big role for us. We also use it in terms of eligibility checks, making sure this patient belongs to a certain plan. So really everything that facilitates the work that the humans are doing. And so for us, it's not been more about AI replacing humans. It's been more about AI augmenting humans, and how can we keep that strategy as we go, because we think AI can help scale trust, but not necessarily replace the humans that build the trust.
Wonderful. All right. Keeping tabs of time here, because I definitely wanted to open it up a little bit for some audience questions. So I'm going to ask this last question, and then we'll open it up for some audience questions. So if you have a question, by the way, and you're out there, and you for any of our speakers, go ahead and drop that now into the question thread. We're going to get to as many as we can. Next question here, though, before we get to that, is the current administration, love it or hate it, is making significant changes to the healthcare ecosystem. What are you doing to be prepared for those changes, and how do they impact your organization? So, Peter, do you want to start with that one?
Yeah, I think that's a good question. I think this it's one of those things that there's sort of two ways, right? There's stuff that we don't fully know yet, as things that, again, some of the rollouts are going to happen over the next few years, and then there's stuff that we do know right now, right? So the way we're preparing for this is some of our plans. So one of the things that this current administration has done, and it's also increasing some of the bureaucratic and red tape on plans, right? So things like Medicaid eligibility has to be done more frequently. I believe it's twice a year as opposed to once. There's a lot of workforce requirements, so it means plans actually have to do more. It means they have to check on their members, making sure these members belong. And so it is created for us, by adding that burden, has created a new opportunity for us, right? So we've been talking with plans because we're meeting these patients in the spaces in the barbershop. So a lot of managed care plans we work with, the state would give them a list of patients. Oftentimes, maybe the contact information is not accurate, maybe where they live is not accurate. So they spend a lot of time trying to reach those patients. We meet them in the barbershop or salon. And so that has become an opportunity for us to see, okay, we're going to see this person once a month, right? And so we can offer, this is a way to simplify your eligibility requirements so that we can make sure that this patient is covered, or if they're not, can we get them signed up to the right insurance plan? So I think as it keeps rolling out, again, that's just an example of a policy that, has created sort of a tailwind for us in terms of how we can work with the plans to simplify their member experience, things like eligibility checks, other issues that could actually improve their care. So we're continuously finding ways and talking to our customers about how we can help them, especially meet these new requirements that have been created by the bill.
Interesting.
I think I'll just add to that. I think Eric covered a lot of the challenges that we face serving a similar patient population within Medicaid and government products. So I do think he covered a lot of the challenges and approaches we are also taking. I'll just add by saying that, there are also opportunities we see here. I think for better or for worse, we're underscoring something that has always been there. There's a high need to support individuals living with serious mental illness, and it's becoming more and more apparent. For us, that means working closely with our plan partners and our prospects to design, creative, responsive ways to serve these individuals across products, across geographies, and really working on a state-by-state basis with how we approach these issues, and adapting quickly as policies evolved, ensuring that, we stay up to date with eligibility checks as well, and no one falls through the cracks during periods of change, which are only going to become more and more frequent, to be honest. So in a way, policy updates present a lot of challenges. They also reinforce and validate our mission and really sharpen our focus on expanding access, deepening our partnerships, serving as someone who can support plans during this time of change and figure out how can we still reach these individuals within a constantly changing government structure.
Yeah, I don't have a ton to add there. I would say this has probably been true for healthcare for a long time. I think that the three businesses represented here, or three solutions represented here, none of us are like nice to haves, right? But there are a lot of solutions out there. And so I think like if you are, another solution that's trying to adjust to this newer administration and these rules that are coming through, you got to find ways to be, part of the core mission of your partners, right? And so today we're talking about care gap closure. I think that's pretty critical, especially as we talk about value-based care stuff. But there's no doubt. I think another decision we made early on, in hindsight, I guess, worked out. But what we're doing is non-billable, right? We're coming out of operational budgets. We're typically the FTEs that you have budgeted for that you can't find or retain is the dollars that we're utilizing. I think on the reimbursement side, yeah, it's just like staying creative, like Nikki mentioned, and staying at the forefront, consistently staying on top of that, and whatever you can do for redetermination and helping those folks is going to move the needle.
All right. Well, let's open it up for some audience questions here. And we do have a bunch of questions that came in. We've got a pretty big audience today. So if we don't get to yours, don't worry. Someone will reach out to answer your question. I noticed some of you asked some very specific questions that we may not be able to answer here. But again, someone will reach out to you. But let's start with this one. And this is just actually a clarifying one for you, Eric. What is, oops, actually, hold on. Let's see, that is not the one. Okay, it says clinical students, quote unquote. Are these college students, med students, high school students, middle school students? What are we talking about here?
Yeah, great question. The network is large. The 30,000 clinical students we have today is large, and that is made up of college, freshman year of college, right? 18-year-old getting an undergraduate degree, all the way to somebody getting, let's say, a mid-level. They're mid-levels. We have medical students, right? So even post-grad folks that are in there. When it comes to hiring, we hire from that 30,000 database. We hire in the 300 clinical students we have today are typically the vast, I would say 60 to 70% are BSNs. So bachelor's in science and nursing students. We require they have some patient experience already. They have to confirm that we're high trust. So we have to confirm all their background checks and all these kind of other access issues that they have. The medication adherence is primarily done by second year pharmacy students, actually. So these are PharmD post-grad, right, students that are performing that level of work. But we have all sorts of other really interesting, CRNAs. We have all sorts of other folks. And then again, the partners get to dictate exactly what they're looking. Some are indifferent. Some are very specific about what they want, even like, regionally what they want. If it's a national client, that's obviously harder to do. But if it's a regional value-based care organization, we can literally set parameters or even require that they're from certain schools.
Great. Next question is for Peter. And this one it says, would Open consider others like mobile mechanic or similar to be part of their model?
Yeah, I mean, we're definitely open to places. I think kind of fundamentally for us is where people go often and that they have a trusted relationship, and really open to whatever the spaces look like. As I said, we started with barbershops, but that's nowhere we're ending. We're starting to do nail salons and estheticians. So are really open to that opportunity because we believe those places can be care hubs, and in places that we're facing significant provider shortages or even rural areas, like that would definitely be open to that as long as it meets kind of that criteria that we have. So for sure.
Cool. All right. Next question is this, and this is for any of you. It says, are any of you handling prior authorizations for medications since the new regulations for more severe mental health medications is now every 3 months? That may or may not be able to be answerable here.
Yeah, no, we do not perform prior authorizations for a number of reasons. One, the work is very nuanced based on the drug or the procedure or whatever is needing to be authorized. And then it's very unique to the insurance or uninsured, et cetera. And so if you have a clinical student workforce who's doing, 250,000 lives in specifically in post-discharge, like we're good at that. You don't want to deploy Grapefruit Health in this like endless number of path kind of solutions. Like that's, we don't take on, we've been asked to do that type of work. We do not do that today.
Yeah, I'll say similarly here at Firsthand, we don't really handle the prior auths. It's just by nature of our work, not something we're involved in. Our priority is just really finding the right medication, the right diagnosis, and at that point, it's really more on the plan side.
Okay, great. Next question, moving right along, and this is again for any of you. What are some best practice tips for closing depression screening and follow-up care gaps? Do you collaborate with federally qualified health centers or FQHCs at all?
I'm happy to hop in for this one. We have many community partnerships. We work with care solutions today to complement them, not to replace them. So when it comes to closing care gaps or anything that is post follow-up, we are either navigating to the right care or providing it. So that could be FQHCs, it could be community healthcare centers, community mental health centers. But regardless of who's actually closing the gap, we just serve as that primary point of contact of either providing or engaging within care.
We're similar, but we do not ever provide the care. So it's more the care coordination around it, and then making that depends on the outcome of the screening. But on the lower acuity outcomes, we are doing care coordination and escalations.
Yeah, very similar to what we do at Oben.
Great. Next question here is, what advice would you have for organizations who are looking to engage with early stage companies for care gap closure? And Eric, maybe we'll start with you on this one.
Yeah, I would, to the extent you can, there's a few different steps. There's like, okay, we're not really sure what we want to do. We're going to go out and do an exploration of like what's out there. And I hope that you got some of that here today in this, but going to conferences, walking booth to booth, Googling, ChatGPT, just try to find out and get a good idea of what's really going on. If you're one step further and you've already defined the needs, so you're saying, we know, for example, that reference, I was referencing the third largest health system group we're working with, they looked at their community health needs assessment and they were doing very poorly in hypertension in a specific region. So they were very, very methodical and said, we want to find a solution to help us address unmanaged hypertension in this rural area of, this happens to be North Carolina. And so they looked for solutions, they learned about what we're doing. And because the work is it's relative, it's very repeatable, right? Hi, we're calling on behalf of you. We saw this score, looks like we have this issue. We could take them down a lot of paths. We can ask about the medications. Do they have them? If not, what are the barriers to those medications? What are those? Anyways, long story short, if you have it really defined, it makes it a lot easier for what you want to do. I think then you need to look at your organization. Are you ready to take on a full, like pure technology play? Like, are you going through an Epic merger or update? Like, probably not going to work if you're going to go full technology, needs to integrate with the EMR to do what you need to do. That's a long path, right? And so as you're looking for solutions, understanding the greater landscape of your organization and what you want to do and what's possible. Another example is like if you're a big CIN and there's 45 EMRs across the CIN, a pure technology solution might not be the best thing for your organization. If you're an isolated 4-hospital provider organization, health system, all on Epic, and you have an incredible IT team with lots of capacity, definitely go full tech. You're going to go, probably it's going to be lower cost, right? So a lot of options there. I hope that was helpful, but there's a lot to that question. But I guess in closing, just understanding the greater landscape of your organization, and then do as much homework as you can on exactly what you're looking for and for which gap.
Yeah, I'd say from our point of view, it's really just looking at outcomes. It's obviously very difficult if you're one of the first customers of an early stage company. So if you don't have the outcomes and the data and the proven success to go off of, then I would say look for an early stage organization that's willing to take accountability for their model. Meaning, are they so confident that you are only paying if there is actually an opportunity for value? And that just comes back to this VBC framework. I think for us, we have seen a proven history of, even beginning with a pilot within a market and then scaling as we continue to see success and increasing your attribution, working with, if you're a national payer, for example, working within one market and then seeing where you can scale to additional markets. But at the end of the day, I really think it just comes to the outcomes and the value that you can prove that you produce and having confidence within that so that it's a win-win situation. And you're not going about the problem in the same way that a plan itself is done. You're complementing what they already have in place and adding to it versus just repeating the same thing that's historically been tried and not really been proven successful to date.
Yeah. Only thing I'd add to that, I think alignment is important as well, in terms of just making sure, work with an organization that really aligns in terms of, what the KPIs are and the outcomes are, like what you want to do. So I think those are really important, at least for us. And also, once you've gone past this first step of trying to figure out what the problem is and you align on this is what the problems are, it's starting small, right? So we had a plan, this was Blues in California. There were 4 care gaps they wanted to close. They have about $18 million at risk. It was hypertension, depression screening, colorectal cancer screening, and diabetes. Again, you don't want to start on all 4. It was, okay, what can we start on to prove that this works? What are the outcomes and alignment, things that we can align on? And what does this look like, post 1 year, 2 years? Like, what are those clinical outcomes, right? So it would be, even though you may want to do all 4, again, working with the company to say, okay, we've done this first one, and then what can we do to scale and grow as we keep building up the solution? So I think those 2 things are something I'd say are pretty top of mind, pretty important working with smaller companies.
Wonderful. Well, folks, we are at the top of the hour, and this has been a great conversation. We do have a couple other questions that came through, but we are out of time for today. But don't worry, someone is going to reach out and make sure they get your questions answered. But I wanted to thank you, Nikki, thank you, Eric, Peter, for a fantastic discussion. If you would like to learn more about Oben, about Grapefruit, about Firsthand, their information is here on this slide. And what we're going to do too is I'm going to send out an email after we conclude, and you're going to receive, it'll be a link to today's discussion, as well as it'll have their emails as well, that if you wanted to be able to reach out to them and again learn more, feel free also to reach out to me, and I'm happy to facilitate an introduction. Again, my name is Garrett Schmidt. I'm the CEO and managing editor of VBC Exhibit Hall, which is where also this webinar will be archived. So if you want to head over to vbcexhibithall.com and go to the library, you can check that out there and find it there. But I wanted to thank you all again so much for joining us today. Thank you again. A special thank you to you, Nikki, Eric, and Peter for joining us. And there's going to be a little survey that pops up when you guys, as soon as we close out. If you have any particular comments, questions, if you want to hear more of this, less of this, if you'd like a round 2, let us know, and we'd love to hear from you. But thank you all again so much for spending your afternoon with us, and hope you have a wonderful rest of your day. Bye-bye now.